while covering the person and checking for visible
Welcome to
injuries
today's
are important.
NCLEX RN
They
review
come after
session
ensuring
on ventilator
airway and
management,
breathing are intact.
tracheostomy care. We have suctioning, oxygenation, and the management of CPAP. And so in this session, we will focus on recognizing and responding to the critical respiratory situations involving these modalities. And we will cover key ventilator settings, recognizing ventilator complications, tracheostomy care and suction techniques, CPAP management, and also to prioritize nursing interventions to prevent respiratory distress, manage secretions, and optimize oxygenation. And again, our goal is to enhance your critical thinking and clinical judgment so you will feel confident answering the NCLEX RN questions on respiratory management. Also, don't forget to let us know how you did in this practice test by commenting below. So let's get into our first question. A patient with acute respiratory distress syndrome has a prescription to use a continuous positive airway pressure mask. What action should the nurse take to ensure this treatment is effective? Options: A, fit the mask securely onto the patient's face. B, measure the patient's initial pulse oximetry levels. C, check the patient's arterial blood gases beforehand. D, take off the masks periodically for deep breathing exercise. The answer here is letter A. And why is A the answer? Well, when you are managing this patient that has acute respiratory distress syndrome who has a CPAP, the most important factor to ensure the therapy is effective is to make sure that the mask is properly fit into their face. And remember that CPAP works by maintaining continuous pressure in the airways to keep the alveoli open, and this is to improve their oxygenation and also to prevent alveolar collapse. Now, if the mask is not fitted correctly, air leaks can happen, and this can reduce the pressure and making the therapy ineffective. Now, without the proper seal, this patient would not receive the full therapeutic benefit, which makes the mask fit a priority nursing action. Now, why is letter B incorrect here? It said measure the patient's initial pulse oximetry levels. Sure, it's very important that we have to obtain the baseline saturation, right? But it only helps with that condition about saturation. However, monitoring is important, and it doesn't really make the CPAP therapy effective, and it's more about checking the results rather than ensuring the treatment itself is properly delivered. Now, what about letter C? Check the patient's arterial blood gases beforehand. So just like the pulse oximetry checking, the arterial blood gases test also provide a detailed picture of the patient's oxygenation, ventilation, and acid-base balance. But again, this is a diagnostic test and an assessment test, not a direct intervention that makes the CPAP effective. So you can have all the lab values in the world, but the CPAP mask is not securely properly, then the therapy will not work. Now, what about D? Take off the mask periodically for deep breathing exercises. Now, I want to emphasize here that the whole point of the continuous positive airway pressure is in the name. It's supposed to be continuous. And so removing the mask can disrupt the therapy. It will allow the alveoli to collapse, which can worsen oxygenation in ARDS. And if the patient needs additional breathing exercises, there are other ways to support them without taking off the CPAP mask. And so the strategy for you to answer this question correctly is to look for that statement to ensure this treatment is effective. While some of the options here are helpful for monitoring, such as letters B, C, which might seem beneficial, but the only answer that directly ensures CPAP function properly is letter A. Let's have number 2. A patient in positive pressure ventilation is set to undergo a spontaneous breathing trial. Which observation by the nurse would most likely lead to delaying the trial? Options: A, pain is being managed with morphine sulfate. B, a cardiac monitor shows newly detected ST segment elevation. C, breath sounds reveal occasional bronchi during auscultation. D, nutrition is being provided via an orogastric tube. The answer is letter B. And why is that? Well, when you're preparing this patient on positive pressure ventilation and for a trial, your priority is to assess whether the patient is physiologically stable enough to attempt breathing without ventilator support. And the goal of the SBT is to see if the patient can sustain adequate ventilation on their own. And so anything that significantly compromises their cardiopulmonary function could lead to postponing the trial. Now, why letter B is correct in this question? Well, a newly detected ST segment elevation on the cardiac monitor is a red flag for the myocardial ischemia. It means the heart isn't getting enough oxygen. And this is critical because weaning of a ventilator is a stressful process that increases oxygen demand. Now, if the heart is already struggling, forcing the patient to breathe independently, it could worsen the ischemia or even trigger a cardiac event. And in this case, when you're delaying the trial to investigate and manage the cardiac issue, this is the safest course of action. Now, what about letter A? Pain is being managed with morphine sulfate. Well, managing pain with the morphine isn't a reason to automatically delay weaning. We know that opioids can cause respiratory depression, but proper dosing and monitoring can ensure that pain control supports rather than interfering with that spontaneous breathing efforts. And so the key clue here is managed, suggesting the pain is under control, not severe or unstable enough to delay the trial. Now, for letter C, another incorrect option, as we know that bronchi are low-pitched, snoring-like sounds that actually indicate mucus or airway secretions. We know that these are significant. It can also impair the breathing, and the key word here is occasional. And this suggests mild airway congestion, which can often be cleared with suctioning. And unless the secretions are severe enough to cause the respiratory distress, the bronchi alone do not warrant postponing the trial. And letter D, another incorrect option, it's stated about nutrition being provided via an orogastric tube. Now, this is a common practice in patients who are ventilated, and it doesn't really interfere with an SBT. We know that aspiration is always a consideration, but nutrition alone isn't a reason to delay the weaning. Now, if aspiration risk was the concern, the question would mention high residuals, maybe regurgitation, or possibly difficulty swallowing, but none of these are present in the case. So for you to answer this question correctly, I want you to strategize, pay attention to the phrase most likely lead to delaying trial. And so what you need to identify here are the most critical factors that would make weaning unsafe. So we know that A, C, and D describe the common patient conditions, but they do not present an immediate threat to the success of the spontaneous breathing trial. And letter B here really stands out because the new ST segment elevation signals a cardiac emergency, and this is the best answer, and there's no reason to this is the best reason that we're going to delay the trial. And when you're gonna see any sudden cardiac changes in a question about a ventilator or when about the ventilator weaning, you gotta pause. Cardiac instability is one of the top reasons to hold off on this kind of trial until further assessment and interventions are completed. So I hope that you got this question correctly. 3. What signs observed by the nurse suggest that a patient with an endotracheal tube connected to a ventilator for pneumothorax management requires suctioning? Select all that apply. Options: A, bubbling secretions seen in the endotracheal tube. B, high alarm pressures triggered by the ventilator. C, patient showing clear signs of agitation. D, moist rattling sounds heard in the lungs. And E, peak inspiratory pressure is low. And F, heart rate at 72 beats per minute. The answer here are the following options: A, B, C, and D. Now, when you are the nurse caring for this ventilated patient with an endotracheal tube, one of your key responsibilities is to recognize when suctioning is supposed to be done. And we know that suctioning is performed to clear the secretions that can block the airway or impair the client's gas exchange, and also something that can trigger the ventilator alarms. Now, the body gives us the warning here when the endotracheal tube needs suctioning, and recognizing these early can help prevent the complications like hypoxia or ventilator-associated pneumonia. And so letter A is stated bubbling secretion seen in the ET tube. This is one of the most obvious signs that suctioning is needed. So if mucus is visibly accumulating and bubbling inside the tube, obstructing the airflow, then you got to clear it with a suction to restore the effective ventilation. Again, the clue here is the word bubbling secretions. Okay, so this signals there is excess mucus that needs to be removed. Now, another option here is letter B, high alarm pressure triggered by the ventilator. And so when the ventilator detects increased airway resistance, it will trigger a high pressure alarm. And the mucus blocking the endotracheal tube can make it harder for the air to pass through. That's why it's going to increase the pressure. And suctioning removes the obstruction and brings the pressure back to normal. So the clue in option B is this: high alarm pressures. Okay, so this basically suggests resistance, often due to excessive or the secretions itself. Now, letter C. This the patient showing signs of agitation. So this could be restlessness or maybe discomfort. Particularly in this ventilated patient, can mean they're struggling to breathe due to an airway obstruction. Okay, signs of agitation, that's already a clue right there. Now, if other causes, let's say pain or could be anxiety, are ruled out, then suctioning may help relieve airflow restriction. And the agitation alone is a nonverbal distress signal for a possible airway blockage. So don't neglect about the clue word here. Now, letter D, it stated moist rattling sounds heard in the lungs. So this could mean bronchi, crackles, which suggest mucus in the airway. And since the patient cannot cough effectively with an endotracheal tube, the suctioning can help clear the secretions, and this will improve their oxygenation and lung function. So pay attention to these rattling sounds. Now, what about the other answers here? The peak inspiratory pressure is low. Why is this incorrect? Peak inspiratory pressure. So, unlike high pressure, this actually signals blockage. When we are talking about high pressure, it said peak inspiratory pressure is low. Now, if this is going to be high, this is going to signal a blockage. And the low peak inspiratory pressure in this option basically suggests a leak in the system, or maybe a loose connection or deflated. So this isn't a problem that suctioning would fix. So we are eliminating letter E. Now, what about letter F? Heart rate at 72 beats per minute. Well, this is not really concerning, right? This is within the range. Now, what you should worry instead is tachycardia, which can signal respiratory distress. And suctioning is also based on the airway issues, not about the stable heart rate. So eliminate this option right away. So for you to answer the entire options for this SATA question, you have to focus on the signs of secretion buildup. So these are things that indicate obstruction, there is impaired ventilation or distress. Now, if an option doesn't directly relate to airway blockage, then immediately eliminate it. So another way of approaching this type of question is to group the choices. So does this option describe an airway problem? Is it mucus? Is it obstruction, distress? So these options probably are likely correct. Now you also have to ask, does it describe something unrelated to secretions? Is it mechanical issue or is it normal vital sign? Then likely that's an incorrect option. So by using that approach, you can confidently pick all the correct options. 4. The nurse has just started the day shift on a busy ventilator weaning unit after a detailed change of shift report from the night team. The unit is managing several patients transitioning from mechanical ventilation following acute respiratory issues. Staffing is tight due to a call out, and the charge nurse has emphasized monitoring for post-weaning complications. Based on the change of shift report, which patient should the nurse assess first? Options: A patient on non-invasive ventilation with a central venous oxygen saturation of 69% using bi-level positive airway pressure. B, a patient who completed weaning, was extubated 4 hours ago, and has not produced urine for the past 6 hours. C, a patient who couldn't sustain a spontaneous breathing trial and is now full ventilation support. And D, a patient with an endotracheal tube in place, monitored continuously for end-tidal CO2 levels. Now, the correct answer here is letter B. And why is that? Well, I want to emphasize here that in a busy ventilator waiting unit, you have to really keep in mind that prioritization is about recognizing the patient at the greatest risk of deterioration. Now, all the 4 patients require monitoring, but the one who just underwent extubation and has not produced urine for 6 hours is the most concerning. And why is that? Well, after the extubation, patients are vulnerable to airway swelling, could be fatigue or cardiovascular instability. And the key phrase in option B, it stated about has not produced urine for the past 6 hours. So this signals possible hemodynamic instability, and we know that urine output is a critical indicator of perfusion. When it drops, it suggests the kidneys are not receiving enough blood flow, which could indicate that the client might be hypotensive, there is systemic stress, or even an early shock. And since this patient is only 4 hours post-extubation, their body is adjusting to breathing without ventilatory support. And if cardiac output or the blood pressure drops, the perfusion to the kidneys basically will decrease, and this makes them the highest priority for the immediate assessment to rule out worsening perfusion or per respiratory compromise. Now, why is letter A incorrect here? This is a borderline low value. We have 69% of SVO2. Not critical. Usually the range in our SCVO2 is around 70 to 80%. And since the patient remains on BiPAP, they are still receiving ventilatory support and this reduces the immediate risk of respiratory failure. And so there's still a need for monitoring, but there is no urgent intervention required at this moment. Now, what about letter C? This is a patient who failed spontaneous breathing trial and now is back on the full ventilator support. Now, take a look into the option, into the clue here. Couldn't sustain a spontaneous breathing trial. Resting now, or it's now on a full ventilation support. And so this simply means that the patient failed weaning, but the ventilator is ensuring adequate oxygenation. Even though the failure to wean is concerning, but this patient is currently stable. And so this makes this patient a lower priority than someone who is post-extubation and potentially deteriorating. Now, what about letter D? A patient with an endotracheal tube in place, monitored continuously for end-tidal CO2 levels. Well, what is this? The ETCO2 monitoring will actually help detect any early ventilation issues, but the endotracheal tube ensures a protective airway. And so, unlike the extubated patient we have in option B, this client in option D has a secured airway and continuous monitoring, making them less of an immediate risk. And so I want you to pay attention to the clue words for the correct answer. It said 4 hours, extubated 4 hours ago. So there's recent extubation, and the client is a higher risk for respiratory and hemodynamic instability. And also it stated about no urine output for the past 6 hours. So this simply reflects that there is possible hypoperfusion, which is an urgent red flag. Now, for the options that are incorrect, so if you look into the other choices here, with the one that is on the BiPAP in option A, the patient still is receiving support. So it's not a patient that has a need for a critical intervention. And you have a patient that is on C that is placed on full ventilator support. The client is stable in ventilation, so the client is not going to get the highest priority this time. And letter D, the client has endotracheal tube in place. It's secured, so there's also lower immediate risk. Alrighty, so I hope that you were able to identify those clues. 5. A patient intubated and on mechanical ventilation following lung aspiration has had their ventilator adjusted to include 7 centimeters of positive and expiratory pressure by the doctor. What anticipated yet unwanted effect of PEEP should the nurse monitor for? Options: A, drop in systolic blood pressure from 125 to 96. B, lowered heart rate from 82 to 60 beats per minute. C, reduced peak pressure displayed on the ventilator. D, rise in rectal temperature from 98.4 to 100.5 degrees Fahrenheit. The answer is letter A. And why is that? Well, when your patient is on mechanical ventilation with positive and expiratory pressure, the goal is to keep their alveoli open and also to improve their oxygenation. However, PEEP isn't without risks, and one of the biggest concerns is how it affects blood circulation. Now, why is letter A the correct answer? Well, it's stated about a drop in the systolic blood pressure from 125 to 96, which is a classic hemodynamic effect of PEEP. And so think about what PEEP does. So PEEP basically increases the intrathoracic pressure, which can compress the major veins, returning blood to the heart. And so less blood coming in means less cardiac output, which translates to lower blood pressure. And so this is a well-known but unwanted side effect, especially in patients who are already hemodynamically stable. And that is why blood pressure monitoring is crucial when PEEP is used. All right, pay attention to the term PEEP. Now, why is letter B incorrect? Lowered heart rate from 82 to 60 beats per minute. This is the warning sign. Now, when PEEP reduces the cardiac output, the body usually responds by increasing the heart rate. That's why there's going to be tachycardia to keep blood flowing. But since this option suggests slower heart rate instead, it doesn't match how the body typically reacts to the PEEP. That's why you're going to eliminate B. What's concerning here is tachycardia, not a heart rate that is within the normal range of 60. Now, what about letter C, reduced peak pressure displayed on the ventilator? Well, the term peak pressure simply refers to the highest pressure reached in the lungs during inhalation. While we know that PEEP affects the pressure at the end of expiration, it doesn't reduce peak inspiratory pressure. And in fact, if the lung compliance worsens due to maybe worsening pulmonary edema, the peak pressure might actually increase instead. And so a decreased peak pressure isn't a known effect of the PEEP. So eliminate letter C as well. Now, what about letter D? Why is this incorrect? Rise in rectal temperature from 98.4 to 100.5 degrees Fahrenheit. Is this really critical? We know that temperature changes aren't caused by a PEEP, and a fever suggests infection like aspiration pneumonia, which might be related to the original lung issue, but it is not a direct effect of the PEEP itself. And since the question is asking for an adverse effect of PEEP, this is not really relevant. And so for you to answer this question, I want you to strategize. You got to focus on the hemodynamic effects when dealing with the ventilator settings. Again, the PEEP is supposed to improve oxygenation, but it can compromise circulation. And if a question asks about complication of PEEP, always think about blood pressure and cardiac output first. Again, if there is going to be hypotension and if there is going to be tachycardia, those are the unwanted effects. 6. The preceptor is assessing a novice nurse caring for a patient on mechanical ventilation with a peak and expiratory pressure of 16 cm water. Which behavior shows that the new RN is practicing safely? Options. A. The RN replaces the ventilator circuit tubing every 2 days. B. The RN employs a closed suction method for airway clearance. C. The RN schedules suctioning of the patient every 1 to 2 hours. D. The RN secures the junction of the ventilator tubing and endotracheal tube with tape. Now, I want you to go back into the question stem. It said, which behavior shows that the new RN is practicing safely? So the correct answer here is letter B. And why is that? Well, let's talk first about what the PEEP here. And in our case, it's 16 cm water. Now, the positive and expiratory pressure is a crucial ventilator setting that will help keep the alveoli open. It will improve oxygenation, and it will also prevent the lung collapse. And normally, the PEEP should be around 5 cm water. Okay, so I want you to pay attention to this. Normal should be 5 cm water. So, well, if in this case we have a client that is now with a 16 cm water, okay, this is a possibility, and this simply means that our PEEP is already high. So again, this is related to any conditions like ARDS, or maybe the client has severe hypoxemia. And so when you are caring for this patient with this level of 16, cm water. The goal is to maintain lung stability and also to maintain oxygenation while we are minimizing the complications. And so the correct answer here is the RN using closed suction method for airway clearance. So this is a standout choice because it prevents ventilator disconnection, and disconnecting the ventilator even briefly can cause a sudden loss of PEEP. This can lead to alveolar collapse and hypoxemia. And so when the nurse is using the closed suction system, it ensures that the airway clearance is done without interrupting the ventilation. So this is the best and safest approach. Now, what about letter A? Why is this incorrect? So the clue here is changing the circuit tubing every 2 days. So this suggests a routine change, which is not recommended. All right. So if there is going to be frequent circuit changes, this is actually going to increase the risk of ventilator associated pneumonia by disrupting the system. And this will also expose the patient to new bacteria. Instead, tubing should only be changed when visibly soiled or if there is malfunction, but not on a set schedule. So this is incorrect. All right. Now, what about letter C? The RN schedule suctioning of the patient every 1 to 2 hours. The red flag here is the schedule. Every 1 to 2 hours. It suggests that suctioning at fixed intervals rather than based on the patient need. And I want to emphasize that routine suctioning can be harmful because it irritates the airway, it can cause trauma, and it will also increase infection risk. And so if you're going to ask about the best practice, well, suctioning only should happen when clinically indicated. For example, if the client desaturates, or if there's visible secretions, or there is presence of respiratory distress. So eliminate letter C. Now, what about letter D? Why is this incorrect? Well, the problem here is the word tape. Okay, securing the tubing tightly using this can actually limit the movement. It will increase tension, which can cause accidental extubation or possibly airway trauma when the patient moves or is repositioned. Instead of doing that, the preferred method is using endotracheal tube holders. Okay, so we'll do that instead of using the tape. So that should be the better option. Okay, and this can allow some flexibility without compromising the stability of the endotracheal tube. And so for you to answer this question, you have to think about promoting lung protection, also preventing complications and preserving oxygenation. And in this case, the closed suction system is the only choice that meets all these criteria, and this is the best answer. Now we have number 7. The nurse is preparing to clear respiratory secretions from an adult patient with a tracheostomy using suction. Which step should the nurse take to ensure the procedure is done safely? Options: A, increasing the patient's oxygen levels by encouraging 4 to 5 deep breaths. B, pushing the suction catheter forward while blocking the Y port. C, using steady suction inside the airway for as long as 20 seconds. D, adjusting the suction pressure to a range of 160 to 180 mmHg. All right, the correct answer here is letter A. And why is that? Well, when you are suctioning this patient with a tracheostomy, the priority is to ensure oxygenation while minimizing trauma to the airway. And that's why the best answer is option A. This can increase their oxygen levels. And take note that suctioning itself can remove both the secretions and the oxygen. So if you're pre-oxygenating the patient, this can help prevent the hypoxia. And if the patient is alert and able, having them take that 4 to 5 deep breaths will do the trick. And if they are ventilated, a manual resuscitation bag or ventilator side function can be used instead. So either way, this step can ensure a safe and effective suctioning procedure. Now, why is letter B incorrect? Pushing the suction catheter forward while blocking the Y port. Well, the red flag here is blocking the Y port. Why is this incorrect? Let me just change the color here. Well, this means suction is applied during insertion, which is a big no-no. Remember that suction should only be applied while withdrawing the catheter. And if the nurse does this step, if they are suctioning while inserting, this can damage the tracheal lining. This will strip away the oxygen. It will also increase the airway trauma. And so this is an unsafe practice. Now, what about letter C, using steady suction inside the airway for as long as 20 seconds? Well, the problem here is the duration, 20 seconds. This is a big no, a bit too long. And so the safe limit for suctioning is around 10 to 15 seconds to prevent oxygenation, but most often 10 is the recommended. And this is to prevent oxygen depletion and airway irritation. So I want you to recall that prolonged suctioning such as this can increase hypoxia and also tissue damage. That's why you have to discard this one. Now, what about adjusting the suction pressure to a range of 160 to 180 mmHg? Well, this is incorrect. Take a look into the pressure. You have to watch out for the high suction pressure. We are supposed to only use about 100 to about 120 mmHg, no greater than that. So if 160 to 180 mmHg is used, this can also cause injury to the tracheal mucosa. This can cause bleeding. It can also worsen airway trauma. So not a good practice. So when you encounter this type of question regarding tracheal suctioning, you have to focus on the oxygenation. You have to maintain patient safety and minimize those complications. So the safest approach here is to select letter A. You have to do pre-oxygenation to prevent hypoxia. 8. A nurse is gradually reducing mechanical ventilation support for a 66-kilogram patient with chronic obstructive pulmonary disease. Which observation in the patient suggests that the weaning process should be halted? Options: A, the patient's spontaneous tidal volume is 420 mLs. B, the patient's respiratory rate is 30 breaths per minute. C, the patient's oxygen saturation is 95%. And D, the patient's heart rate is 98 beats per minute. The answer is letter B. And why is that? And so, if you're the nurse weaning this patient of the mechanical ventilator, especially that they're diagnosed with COPD, the key here is to assess whether their lungs can handle breathing on their own without excessive strain. And so the nurse is watching for signs of distress. Things like rapid breathing, oxygen desaturation, or a dangerously high heart rate, because pushing too hard, too fast can lead to respiratory failure. Now, the goal is to ensure the patient can maintain stable breathing without the ventilator support. And why is B the correct answer here? It stated the patient's respiratory rate is 30 breaths per minute. Take note about the question. Should be halted. Okay? We know that the normal rate is 12 to 20 breaths per minute. And we know that a mild increase is expected during weaning. But anything over 25 to 30 breaths per minute actually indicates the patient is struggling to compensate. All right. So there is struggling here. And the rapid breathing here suggests the lungs are working too hard, and the COPD patient, in this COPD patient rather, this can lead to fatigue and also will lead to respiratory muscle failure. And so in the clinical practice, the rate of 30 breaths per minute is a red flag that the patient is not tolerating the process well, and the nurse should pause the weaning. Okay, there is struggle over here. You should stop the weaning. Now, what about letter A? The patient's spontaneous tidal volume is 420. What does this mean? Well, let's review what a tidal volume is. TD. What does that mean? Well, the tidal volume is that measurement of how much air the patient moves in each breath. And for this patient that is 66 kilograms, the target range is usually around 330 to 528 mLs. Okay. And it's based on the standard of 5 to 8 mLs per kilogram. So that would be our reference. And since the patient's tidal volume in option A is 420, this is basically in the middle. So it suggests that the patient is taking an adequate amount of air per breath, meaning there is adequate lung function and it is also effective. So there should be no concerns here. Okay. So again, take a look into the range for the tidal volume in this patient. So again, it is based onto this standard 5 to 8 per mLs per kilogram. Now, what about letter C? The patient's oxygen saturation is 95. Well, this actually tells us that the oxygen is being delivered effectively to the blood. And again, we are in a safe range here. And for the COPD patients, this is actually acceptable. And in some cases, anyone that may have a range of 88 to 92 is actually also reassuring. So this means the lungs are oxygenating well and there is no immediate dangers of hypoxia. Now, what about letter D? The patient's heart rate is 98 beats per minute. Yeah, the heart rate is working a little harder, but it's still within the normal range. Now, I want to emphasize here that during the weaning, it is also expected that the heart rate will rise slightly due to the increased workload of independent breathing, but this number is not high enough to indicate distress. However, though, if the client's heart rate is about 120 beats per minute, then that would be a warning sign. But here, it's still within the acceptable range. So, when you're being asked with this type of question, I want you to look for the sign that suggests distress or failure. And again, letter B reflects respirations of 30. This is already indicating that the client is struggling. And the tidal volume, oxygen saturation, the heart rate can also give supporting clues. But then again, go back into the sign of distress that is in letter B. 9. A patient with respiratory failure on mechanical ventilation keeps showing arterial blood gas results that suggest respiratory acidosis. What adjustment to the ventilator settings should the nurse anticipate to address this issue? Options. A. Raising the oxygen concentration from 30 to 40%. B. Increasing the ventilation rate from 6 to 10 breaths every minute. C. Lowering the ventilation rate from 10 to 6 breaths every minute. And D. Reducing the oxygen concentration from 40 to 30%. The answer is letter B. And why is letter B the correct option? Well, when you are managing this patient on a mechanical ventilation, it's all about balancing the oxygenation and their ventilation. Now, the respiratory acidosis that is implied in this question, this happens when the carbon dioxide builds up in the blood. It's going to make it more acidic. So there is low pH. And since the lungs are responsible for blowing off CO2, any problem with ventilation can cause this imbalance. And so what is the goal here? Well, you need to get rid of that excess CO2. We don't want this respiratory acidosis. And so that is why letter B is the correct option, increasing the ventilation rate from 6 to 10 breaths every minute. So this is exactly what you want to do when the CO2 levels are too high. And the ventilation rate controls how often the patient breathes in and out, and more breaths mean more CO2 is going to be expelled. And since respiratory acidosis is caused by CO2 retention, increasing the number of the breaths per minute directly fixes this issue. And this is the most targeted intervention for acidosis. Now, what about the other options, A, C, D? Why are they incorrect? So let's take a look into letter A first, raising the oxygen concentration from 30% to 40%. So the clue here is the concentration of oxygen. So this change can affect oxygenation, but not carbon dioxide levels. So eliminate letter A. What about letter C? Lowering the ventilation rate from 10 to 6 breaths every minute. Well, if you're doing that, this would do the opposite of what's needed. So if there's going to be fewer breaths, it simply means that there's going to be less CO2 removed. So this can worsen the respiratory acidosis. Okay. Now, to remember that we have a problem with respiratory acidosis, we need to increase the ventilation rate. Now, what about letter D? Reducing the oxygen concentration from 40 to 30%. Again, the clue is oxygen concentration. Any oxygen concentration cannot address CO2 retention. And this change could lower the patient's oxygen levels unnecessarily without doing anything to fix the acidosis. So this is completely unrelated to the problem that we have identified. So this can worsen, all right? You're not fixing the problem in D, and you're causing a big change in their oxygenation level. Never do that. And so for you to answer this question correctly, I want you to match the intervention to the problem. So remember, if there is respiratory acidosis, there's too much CO2. So what you need to do here, you have to increase ventilation. As easy as that. Okay? So if you're doing the wrong way, if you are decreasing the ventilation, the more that it will cause more CO2 to be retained in the bloodstream. All right, so I hope that you got this question correctly. 10. A patient with respiratory failure is on mechanical ventilation with a peak in expiratory pressure of 12 cm water and has arterial pressure-based cardiac output monitoring in place. Which finding suggests that the ventilator settings might need adjustment? Options: A, heart rate is 56 beats per minute. B, blood pressure reads 91/45. C, stroke volume variation stands at 12. D, stroke volume has increased. The answer is letter B. All right, so why is it the correct option? Well, when you are the nurse managing this patient with a mechanical ventilation with a PEEP, you got to understand how the PEEP affects both the lungs and the cardiovascular system is crucial. I've already mentioned this in our previous question. Now, PEEP, which stands for positive end expiratory pressure, helps keep the lungs inflated by maintaining a constant pressure at the end of expiration. which is important for oxygenation. However, there is that however. If there is way too much PEEP, this can create pressure within the chest cavity, which may impact the cardiovascular system, especially venous blood return to the heart. And that is why B is the answer. This signals hypotension, which is the key finding here. Basically, this is a reflection that there is decreased cardiac output, because again, high PEEP can do that. And so again, think about the increase in the intrathoracic pressure, which can compress those veins, and this will reduce the venous blood return to the heart. And so with less blood returning to the heart, the cardiac output also decreases, which is why you are seeing the low blood pressure. Okay? You got to pay attention to that. Now, since the client has this arterial pressure-based cardiac output monitoring, this will help track the cardiac output. And also, a low blood pressure reading like this suggests that the ventilator settings might be too high for the patient, and it's time to reconsider the PEEP setting. All right. Now, what about letter A? Heart rate is 56 beats per minute. So this is bradycardia, right? But this isn't typically a result of high PEEP or its effects of intrathoracic pressure. What you would be worried instead if there is high peak is tachycardia. Okay? Remember about what I said in the previous test item. There is a compensatory mechanism by the heart because of the hypoxemia. There is decreased cardiac output. So the bradycardia here could be a result to other causes, maybe sedation, and a baseline heart rate for the patient, or even medications should be also, we have to have a comparison. So this is not really directed to the ventilator setting in this context. So there is no immediate concern for the ventilator management for letter A. Now, what about letter C? Stroke volume variation stands at 12%. Well, the clue here is stroke volume variation. So what does it mean? With a 12 variation, this is within the normal range for mechanically ventilated patients. And the stroke volume variation reflects fluid status or the changes in the cardiac mechanics during ventilation. And 12% is not alarming, and it does not indicate that the ventilator settings like PEEP are problematic. And so for the patient to experience negative effects of PEEP, you'd expect a much larger variation or another sign of a compromised cardiovascular function. Now, what about letter D? Stroke volume has increased. Well, the clue is just the phrase itself. So an increase in the stroke volume actually points out, or this reflects an improved cardiac output and also better cardiac performance. Okay? This is a good sign. And in fact, high PEEP is more likely to decrease stroke volume due to reduced venous return from the increased intrathoracic pressure. And so the option in D, where it says increased stroke volume, actually suggests that the patient's heart is compensating well. And this would not raise any concern for adjusting the ventilator setting. So when you encounter this type of question, you got to focus on the interaction between the PEEP and the cardiovascular system. And also remember about what PEEP can do to the intrathoracic pressure. It will cause an increase in intrathoracic pressure. So PEEP can lead to increase intrathoracic pressure, and this can cause a drop in cardiac output, also a drop in the blood pressure. So increased PEEP, just to want to emphasize that. So I hope that you got this question correctly. 11. The nurse is caring for a patient who is intubated and on mechanical ventilation. Which nursing interventions are most critical for lowering the patient's chances of developing ventilator-associated pneumonia? Select all that apply. Options. A, check the patient's readiness to be taken off the ventilator at least once daily. B, conduct sterile suctioning through the endotracheal tube every 2 hours. C, maintain the bed's head raised to a minimum of 30 degrees. D, deliver oral hygiene using chlorhexidine solution at least daily. E, give the patient the pneumococcal vaccine. And F, utilize a kinetic bed to shift the patient's position continuously. What are the answers here? Well, these are options A, C, and D. So, when you're caring for this patient that is on ventilation or ventilator, and also when you're preventing the VAP, again, this is a huge risk for this type of patient. And we know that VAP is a serious complication that can happen from prolonged intubation, which allows the introduction of the bacteria from the outside environment to travel into the lungs because they no longer have the normal defense. And certain actions or interventions have been shown to significantly reduce the likelihood of a VAP. And these are commonly part of the ventilator bundle. So these are a set of best practices that is designed to minimize this risk. And so why is letter A one of the correct options? It's stated, check the patient's readiness to be taken off the ventilator at least once daily. So it's stated about daily assessment. Okay, daily check. So this is actually one of the most effective ways to lower the chances of developing VAP. And the longer a patient stays intubated, the higher the risk of infection. So you got to do this in order to lessen the occurrence of the VAP. Now, what about letter C? Maintain the bed's head raised to a minimum of 30 degrees. Why is this a correct option? Head raised. That's a good clue right there. So this actually is a cornerstone of VAP prevention. And this position will also reduce the risk of aspiration, which is when liquids or secretions are actually inhaled into the lungs. And aspiration is a major cause of VAP because it introduces the bacteria from the mouth or the stomach into the lungs. And so when you're keeping the bed raised to the correct angle, this will prevent this from happening. Now, what about letter D? Deliver oral hygiene using chlorhexidine. That's the clue here. Oral hygiene with the use of the chlorhexidine. This is very critical in preventing the VAP, because we know that the mouth can harbor bacteria that can migrate down the endotracheal tube and also infect the lungs. And chlorhexidine is a strong antiseptic that is used to reduce bacterial load in the mouth. And it will also directly target one of the most common sources of the VAP infection. So when you are performing this daily, this is based on evidence, and also this intervention can greatly lower the VAP risk. And so the other options, letter B, E, and F are all incorrect. Let's take a look into letter B. Conduct sterile suctioning through the endotracheal tube every 2 hours. So this is implied as routine suctioning. We know that suctioning is necessary when secretions are present or the patient is in respiratory distress. But routine suctioning every 2 hours is not recommended unless there is a clinical indication such as visible secretions or signs of respiratory distress. And take note that excessive suctioning can also cause trauma to the airways, and this can potentially increase the risk of infection by introducing bacteria from the upper airway into the lungs. And it is also not part of the core VAP prevention bundle, which emphasizes interventions that are evidence-based and targeted. All right. Now, what about letter E? So let me just mark that as incorrect. E is also incorrect. Give the patient the pneumococcal vaccine. Well, we know that this vaccine can help prevent pneumococcal pneumonia, which is a type of lung infection caused by a specific bacteria. However, VAP is more commonly caused by hospital-acquired pathogens like gram-neg bacteria, but not pneumococcus bacteria. And the pneumococcal vaccine doesn't target the pathogens most responsible for VAP rather, and so making it very irrelevant in this scenario. And letter F, utilize a kinetic bed to shift the patient's position continuously. We know that kinetic bed can be beneficial for overall patient care by preventing pressure ulcers and improving comfort, but it does not have a direct impact on VAP prevention. And again, VAP is primarily linked to factors like aspiration and oral bacterial colonization, not to constant movement or positioning of the body. So this action does not fall within the scope of the core ventilator bundle or the strategies that are shown to significantly reduce the VAP risk. And so when you're going to be asked with this type of question, you have to focus on the interventions that have direct evidence-based links to the condition being addressed. And in this case, we're talking about the VAP. All right. So, and also you have to ask yourself, is this intervention going to target a known risk factor? Okay. So also ask yourself, is the intervention part of the best practices or a ventilator bundle, which is basically designed specifically to address the VAP risk? So in this case, interventions like oral hygiene, head of bed elevation are the core measures that will target the aspiration and infection directly, while the other actions like routine suctioning or using a kinetic bed are not supported in the sense. All right, let's have number 12. A patient having an asthma attack begins showing a slowed heart rate and reduced wheezing. What should the nurse do first? Options. A, prompt the patient to cough and take deep breaths. B, contact the healthcare provider. C, give IV methylprednisolone or Solumedrol. D, record the changes in the patient's breathing pattern. The answer is letter B. Now, when a patient is experiencing an asthma attack and when they suddenly show signs like a slowing heart rate or maybe reducing wheezing, these are red flags indicating a serious deterioration in their condition. Well, normally we know that wheezing is the hallmark sign of asthma, indicating that the airways are constricted but still have some air moving through. However, a decrease in wheezing may suggest that the patient is no longer able to move air through the lungs, which can be a sign of severe airway obstruction or an impending respiratory failure. And at the same time, a slowed heart rate, take a look into the case, reduce wheezing and slower heart rate. This also suggests that the body is struggling to compensate for the reduced oxygen levels. So again, from let's say tachycardia and it's going downhill. So again, that is already a sign of struggling compensation. So this is closing to the incident of respiratory arrest. All right. Now, what about letter A? Prompt the patient to cough and take deep breaths. Why is this incorrect? Well, the patient is likely experiencing respiratory failure or nearing it, and so they won't have the strength or airflow necessary to cough or take deep breaths. And encouraging the patient to do so could waste the critical time, and this may cause further exhaustion, and this will make the situation even more dangerous. And so this approach would not provide immediate relief, and this could delay the necessary interventions. So we're going to mark this as incorrect. Discard that one. Now, what about letter B? Contact the healthcare provider. Well, you have to alert the healthcare provider this time. We have to escalate the care because this client will need intubation and mechanical ventilation. So this will be very critical to prevent further deterioration, and this will also ensure that that the response can be as swift as possible. Ideally, we are actually saving the patient's life. And so that's correct, right? What about letter C? Give IV methylprednisolone. We know that methylprednisolone is a steroid, right? And this is also important in treating inflammation in the airways, but their action is delayed. So they can take hours to reduce the inflammation and open up the airways, so making them ineffective as first-line intervention in a life-threatening emergency like this. What we need this time is immediate intubation, right? And we have to contact the healthcare provider, and also making sure that we are implementing this in a very prompt manner. Now, what about letter D? Record the changes in the patient's breathing pattern. Why is this incorrect? We know that documentation is very critical, right? But it is not priority in this situation. The focus for you to do, or the focus that you should be doing, is on intervening to prevent the respiratory failure, not on recording the information. Okay, so your strategy to correctly answer this question, you have to recognize the emergency situation first. You got to prioritize the action, and also the action should be based on the immediacy and severity. So you have to ask, is the intervention targeting the immediate threat to the patient's life? And so in this case, we have a respiratory failure coming in. And so also ask yourself, is the intervention providing an immediate impact, or is it resolving the issue? So if not, then you are delaying the treatment. So better discard that option. Okay. Alrighty. So let's have number 13. The nurse is tasked with caring for a patient on mechanical ventilation. Which task can the nurse assign to a skilled assistive personnel? Options: A, verifying that the ventilator settings match the prescribed orders. B, evaluating the patient's breathing condition every 4 hours. C, measuring vital signs and oxygen saturation levels every 4 hours. D, monitoring the patient's need for tube suctioning every 2 hours. The correct answer is letter C. Now, when you're considering delegation to the assistive personnel, it is very important that you ensure that the task matches their scope of practice, which typically includes routine technical duties that do not require complex clinical judgment. And so the task in this question is for you to identify that this patient with a mechanical ventilation and the situation involves critical and delicate care. And that is why letter C is our answer. Okay. The measurement of the vital signs and checking the oxygen saturation levels using that pulse oximeter are fundamental tasks that they can do because they're trained to do it. Okay. And these tasks don't require advanced nursing skills like interpretation of complex clinical data or critical decision making. All right. So that is our answer. And if you selected letter B, that's a huge incorrect right there, because verifying the ventilator setting is complex task that involves not just checking the equipment, but also interpreting whether the settings, the pressure, the rate align with the prescribed medical orders and the patient's clinical condition. And this also requires clinical judgment. No, letter B is also incorrect. Evaluating the patient's breathing. Evaluating the patient's breathing goes beyond their scope of practice. And so this involves the assessment of their breath sounds and the work of breathing and also the overall lung function. So this task requires advanced assessment skills, critical thinking, and also ability to make decisions based on the complex physiological information. Again, this is the scope of the RN. Now, letter D, monitoring the patient's need for tube suctioning every 2 hours. Again, this is requiring an RN to assess, okay? We are not going to delegate this to the assistive personnel because this requires specialized training and the ability to make clinical decisions about the patient needs. And so this is also outside their scope of practice. 14. A patient with acute respiratory distress syndrome is being mechanically ventilated. The nurse notices rising peak inspiratory pressures and a faster spontaneous breathing rate with no improvement in the partial pressure of the O2 levels. What does the nurse suggest to the healthcare provider as the next step? Options: A, increasing the ventilation rate; B, IV sedation; C, administer analgesic; D, introducing a diet rich in protein. The priority here is to select letter B, okay? Because when you're managing a patient with acute respiratory distress on a mechanical ventilator, it's very important to pay attention to both the patient's condition and the synchrony between the patient's spontaneous breathing and also the ventilator setting. Now, in this case, we're seeing rising of the peak inspiratory pressure. That's a red flag right there. Okay? And there is no improvement in the PO2 levels. That's another red flag in this case. And these are actually pointing to the potential fighting the vent. So this is a situation where the patient's own breathing effort conflicts with the mechanical ventilator, and it creates a resistance and also increasing the workload of breathing. Now, why B is correct? Well, the most likely explanation for the increasing peak inspiratory pressure and the rapid breathing is that the patient is trying to breathe over the ventilator. It causes a mismatch between the patient's spontaneous efforts and the ventilator setting. And so the IV sedation in B is the most effective response to this because it helps calm the patient and it will also improve ventilator synchrony. And so by sedating the patient, the nurse can reduce the patient's spontaneous breathing rate, and this will also allow the ventilator to manage their respiratory needs more effectively. And this will also reduce the workload on the patient, and this will help lower peak inspiratory pressures, which can enhance the oxygenation and overall ventilator management. So this intervention directly addresses the core problem. Now, what about letter A, increasing the ventilation rate? Well, it might seem like a way to provide more support, but since the patient is already breathing faster, take a look at this one. All right, that's already a clue right there. This would likely worsen the mismatch. And raising the ventilator rate in this case would not fix the underlying issue of the ventilator resistance. Instead, it could increase dysynchrony, wherein the patient's breathing and the machine's rhythm are out of sync, and this will worsen the problem. And so the solution here is to focus on improving the synchrony, not pushing the patient harder. And so that's why we are not going to increase the ventilation rate. Now, what about letter C, administer analgesics? We know that analgesics are very critical for managing the pain, but there is no indication in the case scenario that the patient is in pain. And the issue here is ventilator resistance, not discomfort. And the administration of pain medication would not help with the rising pressures, or it will not improve oxygenation. So it would not address the immediate needs of the patient. Okay. We can use the analgesic to other situations. Now, letter D, introducing a diet rich in proteins. Why is this also incorrect? Well, we know that this is also important for nutritional support, especially in ARDS. But again, this is not appropriate acute intervention for the current issue that we are identifying. All right. We need mechanical ventilation management. And at this moment, we have to address the patient's ventilator synchrony, and that is the priority. And the changing of the client's diet will not have an immediate impact on the ventilation dynamics. So immediately discard this option. All right. So to answer this question correctly, I want you to focus on the immediate problem rather than long-term or unrelated interventions that are presented in the other options. Okay, let's have number 15. The ventilator's high pressure alarm activates for a patient with acute respiratory distress syndrome. Upon entering the room, the nurse notes the oxygen saturation is at 86% and the patient is straining to sit upright. What should the nurse do first? Options: A, use an ambu bag to ventilate the patient while investigating the cause of the high pressure alarm. B, place an oral airway to stop the patient from clamping down on the endotracheal tube. C, comfort the patient by explaining that the ventilator will handle the breathing. And D, increase the FiO2 on the ventilator to 100% to prepare for tracheal suctioning. The answer here is letter A. And why is that? Well, let's go back into the case here. So you have a patient on a ventilator and suddenly the high pressure alarm blares. That's actually an immediate red flag because it means something is obstructing airflow, either a resistance in the airway, maybe mucus plug, or maybe kinking of the tube, or maybe the patient themselves are biting or fighting the vent. Now, at the same time, their oxygen saturation is 86%. Pay attention to that, which is dangerously low, and they're straining to sit up. Okay? Which actually screams respiratory distress. And at this moment, the absolute priority is oxygenation. So always prioritize that. You need to make sure the patient is getting enough oxygen right now while figuring out what's causing the alarm. And so why is letter A correct? Use the ambu bag to ventilate the patient while investigating the cause of the high pressure alarm. Well, because this is a smart move. You're actually doing things all at once. It will deliver 100% oxygen immediately, which is crucial when the oxygen saturation is at 86%. And it will also help determine the issue. You can feel if there is resistance when you're squeezing the ambu bag. Now, if it is hard to squeeze the ambu bag, there's likely an obstruction, maybe a mucus plug or kinking of the tube. And if it is easy, maybe the vent settings are the problem. So essentially, manual ventilation can stabilize the patient while you are troubleshooting at the same time. Now, why are options B, C, and D incorrect? Let's take a look into letter B. Place an oral airway to stop the patient from clamping down. So basically, the clue here is stop the patient from clamping down. All right. So biting could definitely cause a high pressure alarm, but there's no clear evidence that this is happening. Maybe if it's happening, well, you'd likely see visible bite marks on the tube or hear a high-pitched sound. But even if they're biting, this doesn't really fix the oxygenation problem first. So eliminate option B. Now, letter C, comfort the patient by explaining that the ventilator will handle their breathing. Well, the clue word comfort, reassuring a distressed patient is important, but it does not fix the immediate crisis. There is hypoxemia, and if they're gasping for air, and if there is dropping, there is desaturation, words of reassurance will not resolve the problem. They need oxygen first. And so once you resolve that issue, then you can do the reassurance later. Now, what about letter D? Increase the FiO2 on the ventilator to 100%. Well, the word here is prepare. That's the clue. When you are increasing the FiO2, this could help if the ventilator was working correctly. But the problem in the case is that there is high pressure alarm. Okay? That is the issue here. This tells you that oxygen is not getting through to the patient's airway. And so changing the settings without fixing the obstruction is like turning up the volume on a broken speaker, and it doesn't help if the wires are already disconnected. So you got to pay attention to the clue here. So when you encounter this type of question, always choose an action that directly improves oxygenation and also an option that helps diagnose the issue. And so for letter A, it actually does both. The manual ventilation gives immediate oxygenation to the patient, while it can also help you figure out if there is blockage of the airway, while the other options can delay. All right. Also making assumptions or focus on the non-urgent action. So you are supposed to eliminate all these three. Again, these will delay the treatment. You are compromising the safety of your patient. Let's have number 16. The nurse is watching a nursing student carry out nasotracheal suctioning on an adult patient. Which actions by the student would prompt the nurse to step in? Select all that apply. Options: A, advancing the catheter past the spot where the patient's gag reflex kicks in. B, using intermittent suction on the catheter during withdrawal for 10 to 15 seconds. C, setting the wall suction device to 130 mmHg pressure. And D, inserting the suction catheter in while the patient inhales. And letter E, instructing the patient to cough once suctioning is complete. So the correct answers here are options A and C. So this time I want you to imagine that you are watching a nursing student perform the nasotracheal suctioning on this adult patient. Now, as they're going through the steps, you're keeping a close eye because suctioning, while necessary, can easily cause harm if done incorrectly. And some actions might make you step in immediately, while others are just fine. And so I want you to identify which actions would make you intervene here. And so what about letter A? Advancing the catheter past the spot where the client's gag reflex kicks in. Now, I want you to identify the clue here. It said past the spot where the patient's gag reflex kicks in. This is a big no-no. The gag reflex is the nature's way of saying, stop, you've gone far enough. And so if the student keeps advancing beyond that point, they're actually risking the damage, also the delicate airway structures, and they can also trigger very strong unnecessary gag reflex that can distress the patient. And so you need to intervene this option or this action right away. So you need to stop this. Now, what about letter C? Setting the wall suction device to 130 mmHg pressure. Remember what I said earlier regarding setting of the pressure? This would cause you to jump out at you because this is too high. The safe suction pressure for adults range from about 80 to 120 mmHg, not 130. So anything above 80 to 120 can increase the risk of mucosal trauma. It can also cause bleeding. It can also worsen hypoxia if there is way too much air pulled out. And so you need to step in as the nurse and to adjust the suction to a lower level, okay, or a safer level, I should say. Now, what about letters B, D, and E? These are incorrect options, right? So let's tackle letter B. Using intermittent suction on the catheter during withdrawal for 10 to 15 seconds. Well, remember about the ideal suctioning technique? This is basically what you want for the student to do. This is a safe practice. So you're not going to step into, you're not going to worry about this step. Another is inserting the suction catheter in while the patient inhales. So the clue word here, inserting the suction catheter while the patient inhales. So this is also a correct technique. Think about when a patient inhales, their airway naturally opens up, and this makes it easier for the catheter to go in smoothly. And so this will reduce their resistance and discomfort, and there's no intervention needed here. Now, letter E is also an incorrect option. The clue word, cough once suctioning is complete. We know that coughing after suctioning is a good thing. It will help clear out any leftover secretions that might not have been removed during the suctioning. Plus, it naturally helps the patient re-expand their lungs after the brief interruption in the airflow. And so you as a nurse would not need to step in as well. And so again, go back into the question. This is asking for you to promptly step in if one of these nursing actions or nursing student actions are inappropriate. All right. So again, our correct answers are letters A and C. 17. The RN is overseeing a novice nurse who is about to suction a patient on mechanical ventilation. Which behaviors show that the new nurse understands the proper suctioning technique? Select all that apply. Options. A. The novice nurse employs a twirling motion while pulling out the catheter. B. The novice nurse selects a number 12 French catheter. C. The novice nurse activates suction as the catheter is being inserted. D. The novice nurse uses a sterile catheter and glove. And letter E. The novice nurse holds suction for at least 20 seconds. And F. The novice nurse activates suction while removing the catheter. So, go back into the question stem. It said which behaviors show that the new nurse understands the proper suctioning technique. All right. So the answers here are options A, B, D, and F. All right. So the key here is patient safety. Suctioning is necessary, but it can quickly become harmful if done incorrectly. And so the clue word in letter A, it said twirling motion while pulling out the catheter. So this is exactly what we want to see. And the twirling motion can help prevent the catheter from sticking to the airway lining. It will reduce the risk of mucosal damage. And this can also ensure that secretions are removed evenly rather than just in one spot. So there's no intervention needed in this option. Now, letter B, it said the novice nurse selects number 12 French catheter. All right. So this is also appropriate size for the adults. It's also big enough to remove the secretions effectively without causing any excessive irritation. Now, if the novice nurse picked something much larger, well, this could be too harsh. And if they also picked a much smaller size, then it might not work. And so this option would reflect that the novice nurse is actually doing the right thing. Now, what about letter D? The novice nurse uses a sterile catheter and glove. Of course, right? Sterile catheter and glove are the clues here. This is non-negotiable because when they're suctioning a ventilated patient, everything must be sterile to prevent VAP or other infections. And the fact that the nurse is keeping things sterile, it simply means that they understand infection control for this procedure. Now we have letter F, also a correct option. The novice nurse activates suction while removing the catheter. Yes, while removing the catheter. This is also a correct technique. And again, we know that suction should only be applied during withdrawal, not during the insertion. So this will also ensure secretions are cleared efficiently while minimizing oxygen loss and minimizing tissue trauma. All right, let's have number 18. Following suctioning by the respiratory therapist on an intubated patient, the assistive personnel checks the patient's vital signs. Which finding should the assistive personnel be told? Which finding should the assistive personnel be told to report to the RN right away? Options: A, respirations of 22 breaths per minute. B, tympanic temperature reading of 101.5 degrees Fahrenheit. C, pulse rate of 96 beats per minute. And blood pressure for D, 165/88 mmHg. The answer is letter B. And why is B the correct option? Now, When you are encountering this type of question, always think about what could cause the immediate harm to the patient. And while abnormal vital signs can all indicate any potential issues, the infection in the intubated patient is a critical concern because it can quickly lead to VAP and sepsis. So, B, showing a temperature of 101.5 via tympanic thermometer basically reflects that there is an ongoing infection going on. This is a risk, and that should immediately raise a red flag. This is a must report situation. Now, what about letter A? Respirations of 22 breaths per minute. Well, remember that when the client just had a suctioning performed, okay, this can cause a brief respiratory change due to the airway irritation or the stress. But the key here is that it's not dangerously high or low. So there's no immediate need to call the RN unless it keeps rising or there are other distress signs to appear. Now, what about 96 heart rate here? Is this going to be concerning? I guess not, all right? This is also within the normal limits, and we know that suctioning can cause temporary heart rate fluctuations due to the discomfort or mild hypoxia, but this finding is not alarming itself. What about letter D? Blood pressure of 165/88. This reading is elevated, but post-suctioning, BP can also spike briefly due to the stress, maybe pain and agitation. And unless the patient is showing signs of distress, let's say confusion or maybe chest pain, or let's say worsening dyspnea, this isn't as concerning as the fever that we are looking at in option B as well. So, final takeaway here, the temperature that is elevated, this is really concerning because it means that there is infection going on. This can progress to VAP and sepsis. 19. While the nurse is adjusting the ties on a tracheostomy tube, the patient coughs, causing the tube to come loose. What should the nurse do first? Options: A, use a manual resuscitation bag and face mask to provide ventilation to the patient. B, contact the respiratory therapy team to replace the tracheostomy tube. C, notify the primary healthcare provider to reinsert the tube. And D, place a sterile dressing over the tracheostomy opening to avoid infection. The answer is letter A. And so whenever you see a question regarding airway compromise, all right, this is basically a compromise here. The tube is coming off. You should immediately go to the ABCs, all right? And so in this case, the tracheostomy has come loose, meaning the patient's airway is no longer secure. And that is a life-threatening problem. And if you do not act fast, the oxygen levels will drop. It can lead to respiratory distress or even cardiac arrest. And so the clue here is tracheostomy tube came loose. All right? These are emergencies, or this is basically an emergency, and you should act on this one to restore the breathing right away. And that is why letter A is the best option here. So when a tracheostomy tube becomes dislodged, the patient's ability to breathe is already compromised, and you need to manually resuscitate the patient using the ambu bag and also use face mask, or maybe, yes, this is the first priority to ensure the patient is getting oxygen while the airway situation is being managed. And so without the ventilation, nothing else really matters. And so this intervention buys you time to get help and also fix the issue without the patient becoming hypoxic. And we have options B, C, and D is incorrect. Let's take a look into letter B. Contact the respiratory therapy team to replace the tracheostomy tube. Yes, the respiratory team will eventually need to replace the trach tube, but calling them wastes valuable time because the patient isn't breathing properly right now, so you cannot afford to just wait for help. And oxygenation comes first, and you got to get that bag mask ventilation going. Then you got to make that call for a backup. Now, what about letter C? Notify the primary healthcare provider to reinsert the tube. Well, this is also important, but only after you have stabilized the patient. The doctor isn't the one restoring the airway. You are the one responsible to do this. So you got to prioritize action over the notification to the medical provider. What about letter D? Place a sterile dressing over the tracheostomy opening to avoid infection. This is not just incorrect, it is also dangerous. If you're going to cover the stoma, you are blocking the patient's only airway. So this makes the situation much worse. And infection prevention is not the priority in an emergency. Oxygenation is, okay? So you got to do your letter A. Let's have number 20. A patient in the intensive care unit is intubated and on mechanical ventilation to manage community-acquired pneumonia and COPD. Which sedation medication is the most suitable choice for this patient? Options: A, vicuronium drip, B, lorazepam drip, C, dexmedetomidine drip, D, midazolam drip. The answer is letter C. That's the dexmedetomidine drip. What is this drug? Well, let's go back into this test item first. So, when you are asked about sedation for this ventilated ICU patient, you need to focus on the safety, also focus on the effectiveness and the impact on the respiratory function. So the client in this case has COPD, has community-acquired pneumonia, which means that the respiratory depression is a serious risk for this patient. We also have the clue intubated, mechanical ventilation, and this should immediately alert you to choose a sedative that is effective but won't suppress breathing further. And so this brings us to select letter C. Why letter C? Well, this medication, dexmedetomidine, let me read that again, dexmedetomidine drip. This is the go-to sedative for the ventilated ICU patient because it provides sedation without causing respiratory depression. So this medication works as an alpha-2 adrenergic agonist. It will keep the patient calm, but will allow some level of arousability, which is great for weaning off the ventilator. And unlike the benzodiazepine, the dexmedetomidine drip also reduces the risk of delirium, and it also promotes a more natural sleep pattern. Okay, let me write those down. This decreases incidence of delirium, less chances of delirium, and also it promotes a more natural sleep pattern. So this means there's less time on the ventilator. There's also smoother recovery and better outcomes. And this is exactly what this patient needs. Now, why is letter A incorrect? Vicuronium drip. All right, so this option basically is a trap because vicuronium is not a sedative. It is a neuromuscular blocker. It is a paralytic agent. And so it can keep a patient still, but it does nothing for anxiety or awareness. And if used alone, the patient could be completely paralyzed, but still fully aware and in distress. And that's a nightmare scenario, making this an absolutely wrong choice. Okay? Now, what about letter B, lorazepam drip? Why is this incorrect? We know that this is a benzodiazepine. Yeah, we know that this can provide sedation, but it's not the best choice for ICU ventilation. Why? It lasts longer, it increases delirium risk, and it can slow down the weaning process. Plus, take note about the case here. We have a COPD patient. The benzodiazepine can depress their breathing, making extubation harder. And when there is a better alternative, such as letter C, if this is available, then lorazepam just don't make the cut. Now, what about letter D, midazolam? This is also incorrect, right? This is also a benzodiazepine, right? So this might seem like a reasonable option as well, but it has the same issues as the lorazepam. There's going to be longer ventilation times, there's going to be increased delirium risk, and also potential respiratory depression. Plus, the midazolam can accumulate in the system. This can lead to prolonged sedation and a harder recovery. And this is not ideal when you want your patient off the ventilator as soon as possible. So, the strategy for you to answer this question correctly, you got to look back into the clues that I just pointed out. The key is sedation that avoids respiratory depression. And there's no better choice than the dexmedetomidine drip, which provides just enough sedation without suppressing the breathing. It reduces delirium, and it also helps with ventilator weaning. Okay? Again, this is a neuromuscular blocking agent, paralytic agent. These two, the lorazepam drip and midazolam drip, these are benzos, and already mentioned those bad things that they can do. Let's have number 21. The nurse has finished tracheostomy care for a patient with a tracheostomy tube with a reusable inner cannula. What step should the nurse take right before placing the inner cannula back into the tube? Options. A, lightly tapping it against a sterile container. B, wiping it dry with sterile gauze or a dedicated wipe cleaner or pipe cleaner. C, flushing it with sterile water. D, clearing the patient's airway with suction. The answer is letter B. And why is that? Well, let's go back to the question first. And this is something that is sequence-based nursing question. And the most important thing to focus on is timing. So basically asking what action happens right before the next step in the question. And so the key phrase is right before placing the inner cannula back into the tube. That's the phrase right there. So this means we're looking for the very last step before reinsertion. And there's no other correct option than letter B. Okay? Wiping it dry with sterile gauze or a dedicated pipe cleaner. Because we are talking about tracheostomy, we are preventing complications when reintroducing the cannula. Now, if the inner cannula is still wet from rinsing, it can introduce water into the trachea, which might irritate the airway, or it can lead to infection or lung irritation. And the best way to ensure it's clean and safe for the reinsertion is by drying it with sterile gauze or using a dedicated tracheostomy pipe cleaner. And this method will ensure that the inner cannula remains sterile and free of excess moisture, and making it the correct step to take right before reinsertion. Why letters options A, C, and D are incorrect? Why letter A is incorrect? Well, this might seem logical at first, but after all, tapping something might help remove excess liquid, but this is a sterility issue. Even if the container is sterile, contact with the surface introduces a contamination risk. Plus, it doesn't effectively dry the cannula. So, again, the word tapping should be a red flag. All right, what about letter C? Flushing with the sterile water. This is also a timing issue. We know that flushing happens earlier in the cleaning process, not immediately before reinsertion. And if the cannula is flushed again right before placing it back, it remains wet, it increases the risk of aspiration, it can increase irritation and infection. So the word flushing should signal you that this step is already completed earlier in the process and it is not needed at this point. All right. What about letter D, clearing the patient's airway with suction? We know that suctioning is an essential part of tracheostomy care, but it doesn't make sense to do it at this moment. The airway should already be cleared before cannula care if needed. And we know that suctioning without cannula in place can be ineffective and it may risk injury to the trachea. And the word clearing the patient's airway should make you pause because suctioning is a separate step from cannula reinsertion. It's not something done immediately before it. All right. So final key takeaway here is when you are going to encounter this sequence-based questions, you gotta pay close attention to the wording right before, which means we're at the very last step before reinsertion. So drying the cannula is the best answer. 22. A 48-year-old man is admitted to the ICU reporting increasing shortness of breath, a dry cough, mild fever, general discomfort, exhaustion, and an unintentional 8-pound weight loss over recent weeks. On examination, his lung sounds include scattered crackles during inhalation, and his oxygen saturation drops to 85% when removed from a non-rebreather mask. Initial blood work shows a normal white blood cell count, but raised sedimentation rate and C-reactive protein levels. A chest X-ray reveals widespread bilateral hazy patches. Which actions should the critical care nurse prepare for? So the answer is letter D. That is going to be obtaining blood, sputum, and urine samples for culture, followed by starting corticosteroid treatment. So for a question similar to this, or just this question, especially in a critical care setting, you need to identify patterns in the symptoms and the lab results before choosing the best intervention. So here is the key. You have to recognize that the patient's signs point to an inflammatory lung disease rather than an infection or heart failure. Okay, so take a look into the blood work here. Shows a normal white blood cell count. Okay, there is raised sedimentation rate and C-reactive protein levels. So these are pointing to inflammatory responses. Okay, and the most effective approach is the one that directly addresses the underlying cause, which is why the corticosteroids are the right choice. So it said obtaining blood, sputum, urine samples for culture, followed by starting corticosteroid treatment. So take a look into the other manifestations. There's also widespread bilateral hazy patches, right? Okay. The patient's saturation drops to 85% when the non-rebreather mask is removed. So this is basically a case of progressive respiratory distress. There is dry cough. There's also fever, fatigue, weight loss, desaturation despite oxygen therapy, with hazy opacities on the chest X-ray, elevation of the CRP and the SED rate, with a normal white blood cell count strongly suggests that there is cryptogenic organizing pneumonia, or what we call as COP. Okay, cryptogenic organizing pneumonia. For short, that's COP. In short, that's COP, right? And so what is this COP? This is an inflammatory lung disease. This is not a bacterial infection or heart failure. So the first step is to rule out any infectious cause by collecting the cultures and then begin the corticosteroid therapy, which is the gold standard for treating the COP. So I want you to pay attention to the clue words that point to the answer. There is that worsening dyspnea. Okay? Where is that? Worsening dyspnea, increasing shortness of breath. This means that there is progressive respiratory failure. And the bilateral hazy patches in the X-ray, right? This suggests inflammatory process as well. And the normal white blood cell count, but there's elevation of the SED rate and CRP points to inflammation, not bacterial infection. And the corticosteroid that we have in the treatment in letter D is the key intervention for the COP. And so, why is letter A incorrect? Obtaining an order for echocardiogram and starting inotropic meds. Why is this incorrect? Well, it's because there are no cardiac specific symptoms. The patient does not have jugular vein distension. There is no edema. There are no signs of fluid overload. And the desaturation and the lung findings are due to an inflammatory lung process, not heart failure. And also the mention of starting inotropic medications like dobutamine can help pump failure, but they do not have a role in cryptogenic organizing pneumonia. So this is not going to help. And so the clue in this option is that there are no signs of heart failure. All right. Now, what about letter B? Collecting blood, sputum, and urine samples for culture, then beginning broad spectrum antibiotics promptly. Why is this incorrect? Well, again, like what I have said, this is something that is pointing out to the COP. Again, the client does not have an infection. There is normal white blood cell count. This is an inflammatory process as reflected by the CRP and the SED rate. And so the antibiotics in option B will not treat the COP. So if you're jumping straight to this option, it misses the root cause of the issue. All right. Now, what about letter C? Starting intensive diuretic treatment alongside antibiotics is also incorrect. Why? We know that diuretics can remove or it can treat fluid overload, like in a case of heart failure or let's say pulmonary edema. But this patient doesn't show signs of fluid retention. There's no peripheral edema, no JVD. And this X-ray that we are reading shows pulmonary inflammation. There's no pulmonary edema. All right. And so adding the antibiotics without addressing the inflammation also leaves the underlying issue untreated. So again, there are no signs of pulmonary edema, no JVD, so there's no fluid overload. All right. Again, the whole scenario points to the inflammatory process. So this is going to be treated by the corticosteroid, which is an anti-inflammatory agent. 23. The nurse is supervising a student nurse providing tracheostomy care to a patient. Which step taken by the student would prompt the nurse to step in? A. Taking off the inner cannula and cleaning it with only standard precautions. B. Suctioning the tracheostomy tube prior to starting the care procedure. C. Switching out the inner cannula and wiping down the stoma area. D. Pulling off used dressings and clearing away extra secretions. Now go back to the question stem. You are going to select that option that would prompt the nurse to step in. So you're going to identify the step that is done by the student nurse that is wrong, anything that is inappropriate. So the correct answer here is letter A. Okay, it said taking off the inner cannula and cleaning it with only standard precautions. Now, when it comes to performing tracheostomy care, the most important thing to remember is that the sterile technique is absolutely critical. You're not going to use clean gloves here. You're going to use sterile gloves. You're going to use all the equipment that you're going to be using here that touches the client's airway should be sterile. Okay. And so The most important thing to remember is that the sterile techniques is absolutely crucial. And this patient has that opening directly into the respiratory system. And any potential contamination could lead to serious infections like pneumonia. So with that in mind, we have to select letter A as the action that needs correction. All right. Now, what about letter B? These are all actions that reflect good practice, right? So letter B, it said suctioning the tracheostomy tube prior to starting the care procedure. Right. This is correct. And this is basically what we want the student nurse doing, right? It helps clear out any secretions that might obstruct the airway, and this is going to make it easier to continue with the rest of the procedure. And the goal is to clear the airway so that the care process is as effective and safe as possible. So there's no reason for you to step into this scenario. Now, what about letter C? Switching out the inner cannula and wiping down the stoma area. What is this? Well, switching out the inner cannula and wiping down the stoma are both essential parts of the trach care. And while it is important to use sterile technique when performing these actions, this step itself is also a standard part of the procedure. And as long as the student is maintaining sterility, this is perfectly appropriate. And so the clue words in the option, it said switching out the inner cannula. This is a standard part of the tracheostomy care. And wiping down the stoma area, this is also part of the routine cleaning. It should be provided also to the client. Now, what about letter D? Pulling off used dressings and clearing away extra secretions. Well, this is also expected, right? We want to have infection-free environment around the tracheostomy. As long as these steps are performed with sterile technique, they're completely appropriate, and there's no reason for the nurse to intervene. Alrighty, let's have number 24. A patient in the ICU is receiving mechanical ventilation through an endotracheal tube with the following settings: tidal volume set at 620 mL, ventilator rate at 12 breaths per minute, FiO2 at 75%, and PEEP at 14 cm water. The peak inspiratory pressure reads 45 cm water, and the patient's own breathing rate matches the ventilator at 12 breaths per minute. Arterial blood gas results show pH of 7.24, partial pressure of oxygen 64, and partial pressure of CO2 49. Which finding would most clearly suggest the patient's condition is improving? The answer here is, well, we have the options. A, an increase in the respiratory rate to 14 breaths per minute. B, partial pressure of O2 increases to 66 mmHg. C, peak inspiratory pressure drops to 40 cm water. And D, partial pressure of CO2 decreases to 48 mmHg. This is supposed to be letter C. So, in this case, we are dealing with a patient who's on the ventilator, right? And we need to figure out which finding would most clearly suggest that their condition is improving. And so the key here is to first understand what each of these parameters tells us about the client's lungs and how they are responding to the treatment. And so to start, let's take a look into the peak inspiratory pressure, or the PEEP. PIP. PIP. Where is the peak inspiratory pressure here? Yeah. Do we have a PEEP? All right. So basically, we just look for that one. Oh, okay. It's not in the scenario. So what we're going to need to do here is that we're going to look into the tidal volume of 620 mL. Okay. And we're talking about the setting in the ventilator, right? So what is the tidal volume here? This is referring to the amount of air delivered to the lungs with each breath. And the typical tidal volume for most patients on the mechanical ventilation is 6 to 8 mLs per kilogram. Okay, I've already mentioned this in the previous question. Okay, the tidal volume is supposed to be 6 to 8 mLs per kilo. Okay, and this is going to be adjusted based on the patient's condition. Could be ARDS. ARDS may use lower volume, so closer to about 4 to 6 mLs per kilogram. Now, the significance of the tidal volume of 620, it is within the normal range for many adults, assuming an average weight. And this also reflects the volume of air being ventilated, and if it's appropriately set for the patient's size, this value also suggests the patient is receiving adequate ventilation with each breath. And if the tidal volume were too low, it could lead to hypoventilation. It can also cause carbon dioxide retention, while a high tidal volume could lead to barotrauma, wherein there is lung injury from too much air pressure. Now let's look into the FiO2 of 75. So 75% is the percentage of the oxygen delivered into the patient. Normally, the room air FiO2 is around 21%. Now, with mechanical ventilation, this can increase FiO2 to this level, 75%, to help improve oxygenation, but this is actually high already. Okay, so this is done when the patient is unable to maintain adequate oxygen levels on their own. And so when you see an FiO2 of 75, it suggests that the patient is receiving significant support to maintain oxygenation, especially in a case of respiratory failure. Now, typically, the high FiO2 values are used when the arterial pressure is low despite a lower FiO2, like acute respiratory distress syndrome or maybe pneumonia and other lung conditions. However, prolonged high FiO2 levels can also lead to oxygen toxicity. Now, also in this scenario, you have the PaO2 of 64. Where is that? 64. Okay. Normally, it should be around 80 to 100 mmHg. So a high FiO2 is needed to try to maintain oxygenation in this case. Now let's go into the PEEP, this one right here, value of 14 cm water. Okay, so this is the positive in expiratory pressure at 14 cm water. We know that the PEEP refers to the pressure that is applied to the lungs at the end of the exhalation to prevent alveolar collapse, and so to improve oxygenation and lung compliance. Now, the normal range for the PEEP is typically between 5 and 10 cm water for most patients. Now, 10 to 20, or 10 rather, 10 cm water is the most used setting in patients with mild to moderate respiratory distress or those receiving mechanical ventilations due to pulmonary edema or the ARDS. Now, the PEEP that is set at 14 is moderately high. It's typically used to treat patients with acute respiratory distress syndrome and pulmonary edema, where the lungs have difficulty maintaining inflated alveoli and oxygenation. And the high PEEP can also help to increase the functional residual capacity and also improve the oxygenation by preventing the collapse of the alveoli. Okay, and it will also facilitate better gas exchange. However, if the PEEP is set too high, it can also cause barotrauma. It will worsen right heart strain due to the increased intrathoracic pressure. And so in this case scenario, the high PEEP likely indicates that the patient has significant lung injury or, let's say, compliance issues, or maybe something that could require more pressure to keep the lungs open. So let's go into the options here. Why the letter C is correct. Okay. Again, letter C. Why is letter C? This is peak inspiratory pressure drops to 40 cm water. Okay. Well, like I have said, the peak inspiratory pressure is actually dropping here from 45 cm water. That is our correct answer. Now, why letter A is incorrect? An increase in the respiratory rate to 14 breaths per minute. Well, the increase in their rate of respirations from 12 to 14 does not necessarily mean the patient's lungs are improving. And a small increase in the respiratory rate would happen for a number of reasons. Let's say agitation, maybe discomfort, or patient overriding the ventilator. And this could be a sign that there is increased effort, but it's not a reliable indicator of better lung mechanics of oxygenation. So this change is not necessarily linked to improvement in their condition. Now, what about letter B? Partial pressure of O2 increases to 66%. Well, this is actually slight increase from 64, right? While any increase in the oxygenation is usually a good sign, but this is a small change and it doesn't really reflect a meaningful improvement in the patient. And there could be factors like recent suctioning or maybe a position change or even lab variation could cause this kind of shifting. And the FiO2 is set to 75%. So any small increase in the partial pressure of O2 is not that impressive or significant enough to signal the true clinical progress of this patient. Now, what about letter D? Partial pressure of carbon dioxide decreases to 48 mmHg. Originally, it was 49? Okay, so it went down to 48. So this is only a small change. And in this context of respiratory acidosis, a larger decrease in the PaCO2 would be needed to reflect an actual improvement. And this slight decrease seen here could be due to a variety of reasons, maybe slight improvements like in the patient's breathing or small changes in the ventilator's efficiency. However, in terms of the lung function, this small change does not reflect meaningful progress in the patient's clinical condition. Now, how are you going to answer this question correctly? Well, you have to focus on the parameters that directly reflect the lung mechanics and the patient's respiratory condition. And in this scenario, the peak inspiratory pressure is the most telling factor because it directly indicates how easily the lungs are expanding and how much resistance is present. And always remember, small changes in things like PaO2 or the PaCO2 might not be clinically significant unless they are substantial. And so if you see a question where the PIP or other mechanical indicators are mentioned, that's often the most accurate way to assess the effectiveness of the treatment. And so you got to look for those improvements in things that directly show how the lungs are working, like the peak inspiratory pressure rather than the less direct measures like oxygen or the carbon dioxide levels. All right, let's have number 25. A patient with acute respiratory distress syndrome is using a non-rebreather mask for oxygen delivery, yet arterial blood gas results still indicate low oxygen levels. What step does the nurse expect the healthcare provider to order next? Options. A. Start IV normal saline bolus up to 250 mL per hour. B. Carry out endotracheal intubation and start mechanical ventilation. C. Sound an emergency alert for respiratory alert or arrest. D. Give furosemide 100 milligrams IV right away. Okay. The correct answer here is letter B. Well, in this case scenario, the patient with ARDS is still experiencing low oxygen levels despite being on a non-rebreather mask, which is supposed to deliver nearly 100% of oxygen, right? For a non-rebreather. And so this indicates a non-improving. There is refractory hypoxemia wherein the body's ability to absorb oxygen is so impaired that even high levels of supplemental oxygen are not enough to correct the situation. So this is a hallmark of acute respiratory distress syndrome, which requires immediate escalation in the care. And so why is B option correct here? Well, when the non-rebreather mask fails to improve the oxygenation, the intubation is the next step here. Also the mechanical ventilation. And these two allows the healthcare provider or the team to control the patient's breathing. It will improve the oxygenation. It will also support gas exchange more effectively than a non-rebreather mask. And this is especially true in ARDS, severe ARDS, I should say, where the alveoli are damaged, preventing efficient oxygen exchange, and the body cannot adequately compensate through the natural breathing. And so we have no other better option here rather than letter B. Now, why is letter A incorrect? Start IV normal saline. Why is that incorrect? Well, this option doesn't really address the primary problem with hypoxemia. We know that aggressive fluid resuscitation could worsen the condition by increasing pulmonary edema, right? This can lead to the presence of fluid in the lungs. It is a concern in ARDS, all right? And in ARDS, research supports conservative fluid management to avoid exacerbating fluid in the lungs or injury. And so if you're giving fluids at high rate, this would not improve oxygenation. This can only worsen the patient's respiratory status. So this is why you got to disregard this one. Now, what about letter C? Although the patient has oxygen levels that are low, there is no indication that the patient has reached the stage of respiratory arrest. Okay? All right. And the respiratory arrest occurs when a patient completely stops breathing, which is not yet happening in this case. So instead of waiting for this to occur, you got to do proactive interventions like intubation and mechanical ventilation to prevent respiratory failure. And so letter D, give furosemide 100 milligrams IV right away. We know that this is a diuretic, right? It's going to help reduce the fluid overload. This is something that you will see used in pulmonary edema. But in ARDS, the primary issue is alveolar damage and impaired gas exchange, not just fluid overload. We know that furosemide could help with reducing the fluid in some situation, but it does not directly address the hypoxemia caused by the ARDS. So in this case, ventilation support would be the higher priority other than the addressing the fluid status and giving the diuretics. Let's have number 26. The doctor prescribes a test run of non-invasive ventilation for a patient with a chronic obstructive pulmonary disease showing deteriorating arterial blood gas values. What does the nurse understand about non-invasive ventilation for the COPD patient? Options. A, might decrease the likelihood of needing an endotracheal tube. B, should be delivered through nasal pillows instead of a complete face mask. C, must be approached carefully as it heightens the effort required to breathe. D, will demand substantial sedation to help the patient cope with the treatment. The answer is letter A. And why is that? Because the NIV, such as the CPAP or BiPAP, is a good intervention for those patients with COPD who are showing signs of deteriorating ABGs. And this can also help improve the ventilation without the need for invasive procedures like intubation. So this is a really crucial in treating and also managing the respiratory failure in COPD patients. So in this case, letter A is the best answer. And this can also decrease the likelihood of needing an endotracheal tube. And this also supports the patient's lungs by enhancing the tidal volumes. It will also reduce the work of breathing and can prevent the need for more invasive interventions like intubation by stabilizing the patient's respiratory function. And so the therapeutic goal is to avoid intubation. Okay. And the NIV is often successful in doing just that, especially when applied early in the course of their respiratory distress. Now, what about letters B, C, and D? These are all incorrect. Why letter B is incorrect? Should be delivered through nasal pillows instead of a complete face mask. Well, this statement is misleading because NIV delivery methods, whether through nasal pillows or a complete face mask, are chosen based on the patient comfort or maybe the fit and the clinical situation. So not a strict rule that one is better than the other for COPD patients. So both methods can be effective, and it is important to understand that NIV can be delivered in a flexible manner depending on the patient's needs. So saying nasal pillows are mandatory is incorrect because it actually overlooks the flexibility of the non-invasive ventilation delivery options. Now, while its letter C is incorrect, well, this is actually partially inaccurate. In fact, NIV is designed to reduce the effort required to breathe. It supports respiratory function by increasing ventilation and also unloading the respiratory muscles, which is essential in COPD, where respiratory muscles are often fatigued. And the NIV also improves breathing efficiency and oxygenation rather than increasing the effort required to breathe. So this statement directly contradicts the therapeutic effects of NIV, making it this as an incorrect option as well. Now, letter D, will demand substantial sedation to help the patient cope with the treatment. Well, take note that sedation, it said substantial sedation. This is basically counterproductive and also contraindicated when using the non-invasive ventilation because the therapy relies on the patient's ability to breathe spontaneously and maintaining their airway. And so when the client is sedated, this could impair their consciousness. This will compromise their ability to protect their airway, and it can increase the risk of aspiration. And so heavy sedation is not only unnecessary, but could also increase the risk associated with the NIV. And so when you're answering this type of question, you have to focus on understanding the mechanism of action and the treatment in the question, right? With NIV and COPD, the key point is that it supports breathing and also it reduces the work of the lungs, which can help prevent the need for the intubation. 27, almost there. So the nurse is educating a patient with sleep apnea about home care. Which remark from the patient suggests that more instruction is required? Options. A, I can take my personal CPAP equipment with me if I'm hospitalized. B, I'll wear a positive pressure mask over my face while I sleep. C, I'll have a tube placed in my throat at night to assist my breathing. D, the CPAP device will maintain open airways for improved oxygen flow. There's no other option other than letter C. That is the correct answer. So when you're teaching a patient with sleep apnea about their home care, you have to stress the importance that they understand the proper use and also the purpose of their continuous positive airway pressure machine. And we know that CPAP is non-invasive treatment. So this is going to help keep the airways open by delivering a steady stream of air through a mask. So this will prevent airway from collapsing during sleep. And so why is C correct? we're actually looking for that statement that suggests more instruction is required. So this statement in letter C indicates a clear misunderstanding of the CPAP. Okay, so this mention about the mention of a tube in the throat, which suggests the patient is confusing CPAP with more invasive treatments like tracheostomy or maybe endotracheal tube, which require a tube in place in the throat. And in reality, CPAP uses a mask to provide positive pressure and does not involve any invasive procedures. So this statement is a red flag showing that the nurse need to clarify how CPAP works. Now, the others, A, B, and C, these are all, rather A, B, and D, are all statements that reflect understanding. So with letter A, they can take their personal CPAP equipment when they are hospitalized. And the machine is portable, and many patients choose to bring their own equipment with them to the hospital to ensure they can continue therapy without interruption. And so this is a practical understanding, so there's no further education required here. Now, what about letter B? I'll wear a positive pressure mask over my face while I sleep. Yes, that's also true, right? The patient understands that they will be wearing that mask that will deliver the positive pressures during their sleep. So this will help prevent the airway from collapsing. Now, letter D, the CPAP device will maintain open airways for improved oxygen flow. Yes, absolutely. This is accurate. So this describes the purpose of the CPAP. And the device uses continuous positive pressure just by the name itself. It is to help keep the airways open to ensure improved oxygenation during the sleep. So this is also a correct statement. So we're not going to select that. 28. A patient who underwent a left lower lobectomy due to lung cancer has been transferred to the ICU. 2 hours after surgery, he is fully awake and oriented with stable vital signs, needing 4 liters of oxygen via nasal cannula to keep his oxygen saturation at 95%. Overnight, his saturation drops to 88%. His respirations goes up in the 40s, and he reports worsening pain in his right chest. Breath sounds are audible bilaterally, but weaker at both lung bases. Which initial nursing actions should be prioritized? Okay. Options. A, give pain relief medication and urge the patient to cough and use the incentive spirometer. B, switch to a face mask with 40% FiO2 and draw an arterial blood gas. C, request a chest x-ray to check for hemothorax and increase oxygen to 6 liters per minute. D, provide a sedative and promote deep breathing and relaxation exercises. The answer here is letter A. Now, in this case scenario where a patient who has undergone a left lower lobectomy due to the lung cancer, they suddenly develop a drop in their O2, okay, overnight, 88%. And increased respiratory rate, okay, in the 40s. Take note of those. And also complaining of worsening pain in the, actually this is in the left chest. Basically just chest. And so this is basically a client that is having a post-operative pain. Okay, so why is letter A the correct answer here? Well, this basically focuses on treating the pain, which is likely contributing to the patient's difficulty with the deep breathing and also adequate lung expansion. And after the lung resection, the post-op pain can severely limit the ability to take the deep breaths, which can lead to the atelectasis or the lung collapse. And the coughing and using the incentive spirometer are critical actions to help expand the lungs and also to improve the oxygenation. And so this will help resolve the issue with the oxygen saturation without the immediate need for additional oxygen or any diagnostic test. And so the patient's condition seems related to hypoventilation due to the pain, and managing this is the first priority before escalating the treatments. Now, why are the other options incorrect? We have B, C, and D. Why are these options incorrect? Well, with letter B, switching to a face mask with a 40% FiO2 on draw and arterial blood gas. We know that increasing oxygen and checking an ABG could be useful for evaluating gas exchange. But the patient's respiratory issue is most likely due to the pain related hypoventilation rather than a more severe underlying respiratory failure. So this option addresses the symptom rather than the cause of pain, and it's more invasive than necessary at this point. And so the primary issue is pain management and promoting lung expansion, not adjusting the oxygen flow or performing any diagnostic tests prematurely. Now, why is letter C incorrect? Request a chest x-ray to check for hemothorax and increase oxygen to 6 liters per minute. Well, a chest x-ray might be indicated if there are signs of bleeding or hemothorax, or maybe asymmetrical breath sounds or hypotension, but the patient does not exhibit signs of acute hemothorax, such as unequal breath sounds or hemodynamic instability. And bilaterally diminished breath sounds could be expected after a lobectomy and likely due to atelectasis, which is a common complication after a lung surgery, not bleeding. And so increasing the oxygen might provide temporary relief, but it does not address the underlying pain or the lack of lung expansion, so making this response less urgent than managing the pain. Now, what about letter D? Provide a sedative and promotes deep breathing and relaxation exercises. So this could help alleviate anxiety, but it's not the best approach here. A sedative might cause drowsiness, which could impair the patient's ability to participate in necessary breathing exercises. And the cause of the patient's symptom is more likely to pain and the hypoventilation from the surgery rather than the anxiety. And so relaxation exercises alone would not address the acute issue of atelectasis or improve the oxygenation sufficiently in this phase. All right. Okay. So let's get into our next question, number 29. Let me just take a look real quick. Now let's go into our next item here, number 29. The nurse is mentoring a new RN during their orientation to the intensive care unit. The RN is caring for a patient with acute respiratory distress syndrome who was recently intubated for mechanical ventilation. The preceptor watches the RN carry out several tasks. Which task requires the preceptor to step in immediately? Options: A, utilizes an end-tidal CO2 device to validate the endotracheal tube's location. B, position a mark on the endotracheal tube 1 centimeter beyond its contact point with the patient's front tooth or nostril. C, evaluates the patient for uniform breath sounds and even chest rise. D, arranges for a chest x-ray to ensure the tube is correctly placed. The answer is letter B. And why is that? Well, in this case, the nurse is mentoring the new RN working with a patient who has acute respiratory distress and has been recently intubated. And so the focus here is on ensuring proper placement and management of the endotracheal tube, which is very critical in airway management. And so the task that requires the preceptor's immediate intervention is letter B. It states, positions a mark of the endotracheal tube 1 centimeter beyond its contact point with a patient's front tooth or nostril. Why is this the correct answer? Well, this mark serves as a baseline to monitor the tube's position over time. But if the mark is placed 1 centimeter beyond this point, it introduces inaccuracy, which could cause the nurse to miss potential shifts in the tube placement. And in a patient with ARDS where precise ventilation is critical, any misplacement or movement of the tube could lead to any serious complication. And so you as a nurse mentoring here should correct this action. Now, what about letters A, C, and D? These are all incorrect, right? It said, utilizes an end-tidal CO2 device to validate the endotracheal tube's location. This is actually an action that does not require the preceptor to intervene, okay? Because the device itself can detect exhaled carbon dioxide, which confirms that the tube is correctly placed in the trachea and not in the esophagus. So this is also part of the standard and correct practice. And letter C evaluates the patient for uniform breath sounds and even chest rise. So this is also another standard practice. You need to assess for the bilateral breath sounds and even chest rise to ensure that the endotracheal tube is in the trachea and not misplaced in one of the main stem bronchi. And so if the tube is incorrectly placed, you're going to hear unilateral breath sounds and you will see asymmetrical chest rise. So this is also a huge step in verifying proper tube placement and ventilation. Now, what about letter D? Arranges for a chest x-ray to ensure the tube is correctly placed. Yes, of course. After intubation, it is a must to request for a chest x-ray. And this is also a gold standard for confirming endotracheal tube placement. And this will give us visual confirmation that the tube is in the correct position within the trachea. Okay, this is based on evidence studies, evidence-based practices, and this is also going to enhance the patient's safety and will also ensure that the endotracheal tube is positioned correctly. Let's have number 30. A patient with chronic obstructive pulmonary disease arrives at the emergency department experiencing a severe flare-up. She is barely conscious, breathing rapidly, and has an elevated heart rate. The critical care nurse quickly obtained an order for arterial blood gas with the following results: pH 7.21, PaO2 54, and PaCO2 66. What intervention should the nurse expect to be implemented next? Well, options here. A, starting a non-invasive ventilation with BiPAP. B, administering low flow O2 via nasal cannula. C, placement of endotracheal tube. D, giving an intravenous dose of 50 milliequivalent sodium bicarbonate to address the acidosis. The answer is letter C, placement of the endotracheal tube. Why? Take a look into the case here. We have a client that has COPD, experiencing severe flare-up, barely conscious, breathing rapidly, and we have a pH of 7.21. There's acidosis. The oxygen is really low at 54, and we have a high PaCO2, 66. So there is respiratory acidosis, right? And this is a critical piece of information. And these should prompt you to select letter C, endotracheal tube placement, okay? And the PaO2 points to inadequate oxygenation. This is really low. Supposedly it should be around 80 to 100, right? And so the patient here is barely conscious. likely unable to maintain or protect their airway, which is common in respiratory failure. And the intubation is critically necessary to secure their airway and also to provide mechanical ventilation. And without intubating this client, the patient could lose the ability to breathe. This is going to lead to respiratory arrest. Now, what about letter A? This is incorrect. A, B, and D, starting non-invasive ventilation with BiPAP. Well, remember about the BiPAP that we talked earlier. This can be helpful in some patients with respiratory failure, especially those who are alert enough to manage their own airway and secretions. However, in this case, we have a client that is barely conscious, which means she likely cannot protect her airway or cannot clear secretions effectively. And BiPAP is contraindicated for patients who cannot cooperate or maintain their own airway. So making this as an unsuitable option, right? And so we definitely need to look for the letter C here. Now, what about letter B? Administering low flow O2 via nasal cannula. So oxygen therapy is also critical for improving oxygenation in patients with COPD. Low flow oxygen via nasal cannula won't be enough in this case. Your client already has look at the values here. These are life-threatening values. So the PaO2 alone is very critical. So there is severe hypoxemia. And if you're just simply providing low flow O2, this will not address the hypercapnia. There is already high CO2 levels, and this will not provide the necessary ventilatory support. And so this is going to be insufficient. What about letter D? Giving an intravenous dose of 50 milliequivalent sodium bicarbonate to address the acidosis. We know that sodium bicarb is sometimes used in metabolic acidosis when the pH is very low, less than 7.1 or below. However, in this case, the acidosis is respiratory in nature, not metabolic. So this is not going to help correct the issue. The best way to correct the respiratory acidosis is improving the ventilation to lower the CO2 levels, not by administering the bicarbonate. And so this would not address the underlying cause of the acidosis and could be premature as well, because bicarbonate is not typically indicated for this type of acidosis. All right. And so when you see the ABG results in this case, pay attention to the CO2, the O2, and the pH. Always assess the primary problem first. And in this case, the elevated PaCO2 suggests respiratory acidosis, and there's also hypoxemia. So you need to eliminate those options that involve non-invasive interventions if the patient is too unconscious or unable to protect their airway. And you also remember that when dealing with respiratory emergencies, the patient's ability to maintain airway and ventilation is key. So you gotta prioritize interventions that provide ventilatory support, such as intubation, over low flow oxygen supplementation or other methods that do not address the ventilatory failure directly. And so that is the end of our exercise today. And so again, to wrap up, we have covered essential respiratory management topics, including ventilator settings, tracheostomy, care, suctioning, oxygenation strategies, CPAP, BiPAP management. And we hope this presentation helped you to recognize the complications, prioritize the interventions, and also apply critical thinking in real-world NCLEX scenarios. And I want you to remember that always assess airway and breathing first in any respiratory distress situation. You got to know your ventilator setting and how to interpret ABG results for necessary adjustments. And also recall about tracheostomy and suctioning. This will require sterile technique to prevent infection. And CPAP and BiPAP can be life-saving. So you got to monitor patient compliance and to troubleshoot those alarms. So I hope that you're going to do some more practices with this type of questions. The more confident that you'll become in handling ventilator and oxygenation related NCLEX questions. So keep up the hard work, and you are one step closer to passing the NCLEX RN. So again, let us know how you did in this practice test by commenting below. Show us if you are learning anything. So see you again next time.